So, dear colleagues and friends, thank you very much for the invitation, the opportunity of being here with you. So, I would like to talk about radiofrequency ablation, RFA ablations for thyroid nodule in a surgical department, in an endocrine surgical department. So, you know that endocrine surgery is a dedicated, integrated approach that's spreading worldwide with general surgeons, endocrine surgeons, and most of the cases we have to manage is thyroid pathology and specifically thyroid nodules. You know, with the emerging concept of precision medicine, we have to manage a very, very common situation, patients referred with thyroid nodules. And finally, that with agings above, everybody is going to be affected. But the question remains the same: which patients should be followed, which patients should be treated, RFAs, surgery, and how the patient should be treated. In France, it's considered a public health issue, and what is interesting that the interpretation of this public issue is so different from GPs, from physicians, medical physicians, endocrinologists, and from the surgeons. So endocrine surgery is a part of general surgery in France, and endocrine surgery, general surgery, is still leading on thyroid surgery in France compared to ENT. So with aging of the population and liberal ultrasonography, we have more and more patients referred to the outpatient clinic for managing thyroid nodules, with the increase, as we all know, of the microcarcinoma, but also the increase of macrocarcinoma from the thyroid. So you have to know that in the 70s in France, general surgeons completely miss the opportunities of diagnostic endoscopy, and they became really dependent of gastroenterologists. So when RFA was raised for thyroid nodules, it represents an issue, a challenge, and an opportunity for general surgeon. So usually indications for nodules will be symptoms, the size of the nodules, suspicious nodules, equivocal nodule, toxic, and so on. But what we observe about the two last decades, over the last 20 years in France, is that with the standardization of ultrasound, with thyroid classifications, with the beta scoring system, there was a decrease for thyroid surgery, moving to 50,000 to about 40,000 thyroid surgery a year in France. On the other hand, with the aging of the population, the liberal ultrasound, there's a big increase of thyroid cancer diagnosed and operated on in France over the last 20 years, ranging from 2,000 to almost 10,000 cases a year. So why RFA was introduced in a surgical department and not in a radiology or endocrinology department? In the department, we have a very long tradition, almost 40 years of doing our own FNA. We were used to have ultrasound in the OR and the clinics, using it for parathyroid focused approach, for thyroid evaluation of lymph node and thyroid cancer. We were used to do US guided FNA in the departments, much more than the radiologist or the endocrinologist. So the surgeons were experienced with US. In 2014, we have several meetings with the current company, StarMed company, and they're wishing to introduce their technique in Europe, in France, and they were prone to introduce the technique to surgical departments. So we sent first surgeon of the department in Korea to be taught there, and the second one in a teaching center in Italy. And maybe the most difficult part was the negotiation with the hospital administration. Why? Because RFA is not a standard at all in France for thyroid nodule. There's absolutely no recognition by the national healthcare systems. So there's financial issue for the hospital. Regarding the money, it's the probe. The cost of the probe is about 1,000 euros, and the cost of the generator is about 40,000 euros. So some technical points. Using StarMed material, we use cool electrodes with a transseismic approach described by Professor Sebag from Seoul with the motion technique. We'll go further on the slides. So you see the material. Usually we use the smallest probes, 7 to 10 millimeters. So we have to keep safe distance. for the supposed position of the inferior laryngeal nerve. We have to, for the carotid sheath, for the trachea, and so on. We have to deliver progressive energy, and we have to rely on the pain of the patients, because the procedure is done under local anesthesia. We have to rely on the impedance of the probe, and when the nodules and the shot is turning hyperechoic, we are moving to the next shot. You know that the idea is to raise the energy to obtain between 50 to 70 degrees Celsius, that you will induce coagulation and necrosis, but no damage as boiling the nodules or carbonization. So what was the indications we tried to build around this new technique in the department? For sure, it relies on the size. And you will see that there's a big, one of my opinion to evaluate the results, the big issue is that how will you measure the nodules in diameter, in volume, and you see with the formula that there's a big difference in evaluating the nodules compared to diameter to volume. Symptoms, and finally, the indication rely on mostly on solid nodules, rely on Siret's classifications. We have to be very cautious with some localization close to the trachea, the position of the phalangeal nerve, the carotid sheath, and so on. We are very reluctant to plan several sessions, and to date we consider that we have to treat the patient in one session, or if it's not a good indication. For the age and the comorbidities, we rely on a personalized approach, patients to patients. But what is mandatory in our opinion, that we need to have 2 ultrasound-guided FNA recently with a beta score of 2. For sure, we need informed consent, signed informed consent from the patients, and the patient have to receive the information. That will be a partial treatment, probably a temporary treatment of the nodules. All cases are validated in a multidisciplinary meeting at the same time of the endocrine oncologic multidisciplinary meeting before doing the procedures. So evaluation rely on volume decrease, rely on the symptoms, but with the visual analogic scale, some cosmetic evaluation. And the standard in literature is to consider that if you have a volume decrease of 50%, it's a success. But you will see that it's very debatable, because 50% decrease in volume, when you look at the diameter and the evolution of the diameter of the nodule, it strikes dramatically less than the reduction of the volume. So time endpoint should be at least 6 months. Between 6 and 12 months, you will have an idea of the volume. So we sent a surgeon summer 2004 in Korea with initial experience. And after escaping from the financial barriers, we did some mental cases. And we started our own experience in 2016. That represents in the department between initially 3% and now about 8% of the procedures done compared to thyroid surgeries. So mean treated volume lasts about 12 cc, it's not big nodules, no bigger than 4 centimeters. When we evaluate the result for all available patients at 3 months, we have a 59% decrease, and success rates could be 77. But you could see that if we go for the 31st patients, and after the 30 patients, success rate was much better. Relief symptoms was above all patients, but it's a subjective opinion, and I think there's some placebo effect on the patients. So we had some complications. We had 2 capsular disruption, 1 transient vocal cord palsy, confirmed by direct laryngoscopy, but these complications occurred in the 21st procedures. We have very significant post-op pain in 2 patients and some superficial anterior hematoma, but with no consequences, no long-term consequences. One point I would like to raise is that when you analyze in the literature complications, there's about 1% of voice change, but no patient underwent direct laryngoscopy. And in my opinion, it's a very optimistic evaluation of the inferior nerve palsy in this kind of procedures. And my opinion is that it's very close from the rate of complication you could have after surgery. In the department, after several procedures, we ended to do systematic direct laryngoscopy after procedures. I think it's an error, and we should go back to do that for every patient. So, as you could see, we already lost about 10 patients for follow-up because I think the feeling of the patient is that it's a minor procedures, so I don't have to be followed, and the patient is lost for follow-up very early in the course. So we have a very low decrease in 6 patients. We had a slightly increase of the volume of the nodule in 2 patients. We have some patients with persistent symptoms. And finally, in our own experience, we go to surgery for 1 patient after 1 year. We have at least, I would say, like 1 persistent toxin nodule and probably another patient. And we had a completely failure in a predominantly cystic nodules. So what would be the next issue in our opinion, in our surgical department for FRA? My opinion that one of the big issues we have to manage is that B2 FNA, beta score 2 FNA, is not predictive for large nodules over 3 or 4 centimeters. Even if you repeat US-guided FNA, you will decrease the rate of false negative, but you will miss probably in large nodule some papillary thyroid cancer. So should we go further to raise the volume of the nodules, number of sessions for each nodules? Should every patient be selected from MDT? We believe in that. The other issue we have to confront in France is there's, to date, no recognition of the healthcare systems. It appears some savage private centers that ask the patients a large amount of money to treat nodules, and we're starting observing some complication. Another issue is consideration for cancer, for recurrent cancer, and what would be surgery if surgery is required after FRA procedures. We did 2 cases referred in the department after very liberal and, in my opinion, very aggressive FRA procedures, and that was very, very complicated and very tough surgeries. So I will be reluctant about the indications. So some conclusion perspectives. So it's technically feasible. In my opinion, it's feasible, especially for the surgeons who are used to manage with ultrasound. And because I think the surgeons is more prone to have like a 3D vision, reconstruction, the knowledge anatomy is much better maybe than the radiologists or the endocrinologists. I think the learning curve is not so long, between 30 to 40 cases. If the surgeon is used to ultrasound, he have a proper education and some good mentoring. The multidisciplinary approach is still mandatory in my opinion. The other point that there should be no economical or strategic issue in introducing the techniques somewhere. And in my opinion, that the surgeon's investment in that technique is needed because it will be a warrant for a proper evaluation of the introduction of the technique. So in the department, we're still reluctant for large and massive goiter. We're not convinced for toxic nodules, and cancer should be considered very, very selectively. But for sure, we'll go on, and our ambition is to be a teaching center in 2020. So despite restrictions, there are so many patients that are good candidates that for sure will go on. To finish, I would like to thank several people. I would thank Tol Yalon from Sheba Medical Center that accompanied me for this congress. I would like to thank the Israeli Surgical Association to receive me here with my family, and very happy and very proud to be here with you. I would like to thank Svaim, who is a non-profit organization drawing lines between France and Israel in medical issue. And I would like to thank some friends. My colleagues in Marseille are doing still FRA, and when I'm out, they remove very large tumors at the same time. I would like to thank Eric Seton, who's one of the people that makes me here, and especially Professor Aviram Nitzan from Sheba Medical Center. So thank you very much for your welcome.